Hello, everyone, and welcome to the Patient Health Alliance NMOSD Master Class. The Patient Health Alliance is a source of information and education for NMOSD and related conditions. The content of the following presentation is based entirely on published data or expert opinion. PHA is not a clinical provider and does not offer diagnostic, therapeutic, or clinical care recommendations or advice on personal health. All patients and caregivers are advised to consult with their healthcare team for specific information. The goals of today's NMOSD Master Class, and indeed all of the segments in this series, are to provide a practical update of the latest information on a specific topic, to illustrate key themes and/or clinical pearls, are formatted to be inclusive of non-specialist audiences, and provide an active Q&A discussion time to emphasize some key points. My name is Dean Wingerchuk. I'm a neurologist and serve as the chair of the Department of Neurology at Mayo Clinic in Arizona. I'm also an advisor to the Patient Health Alliance. I'm delighted today to introduce our featured speaker, Dr. John Chen. Dr. Chen is a professor of ophthalmology and neurology at Mayo Clinic in Rochester, Minnesota. He's a neuro-ophthalmologist and an expert in diseases such as NMOSD, MOGAD, multiple sclerosis, and other related autoimmune conditions. He sees patients and does research in this area. Today, he'll speak to us about a clinical evaluation of vision. I'll turn it over to you now, Dr. Chen.
Dean, thank you so much for that introduction, and I look forward to talking to you about the clinical evaluation of vision, especially in terms of how it pertains to NMOSD. So essentially how NMOSD tends to affect the vision is through optic neuritis. And an optic neuritis is an inflammation of the optic nerve. It's actually the most common cause of optic neuropathy in young patients, but it can affect any age. And typically with optic neuritis, the vision loss actually drops over several days. A sign that vision loss is from optic neuritis is there's often pain, especially with eye movements. And when we get an MRI, we'll often see inflammation of the optic nerve. This whitening of that optic nerve kind of helps us say this is optic neuritis. And when we look at the optic nerve itself, there might be some mild disc edema, depending on the cause of the optic neuritis. And for typical optic neuritis, like multiple sclerosis, 90% actually improves at 20/40 or better. But unfortunately, with NMOSD, the visual outcomes are much worse. And so when we think of optic neuritis, we have three main types. Multiple sclerosis is the most common cause, especially among white patients. And in terms of how severe the outcomes are, there's a couple areas of vision that we tend to look at. 2200 or worse is considered legally blind. And so that's an outcome that we obviously don't want to have for any of our patients with optic neuritis. And with MS, about 3% of patients with MS optic neuritis end up legally blind. Another important threshold of vision is 20/40 or better. That allows you to drive without restrictions. And you can see here after MS optic neuritis, 92% of patients are able to achieve a vision of 20/40 or better. Now, for NMOSD, these patients tend to have much more severe disease. This is just an example of a patient we saw in the neuro-ophthalmology clinic. This was a 36-year-old African-American female with a history of optic neuritis in the right eye, leaving her with count fingers vision and a very pale nerve. So her vision was so bad she couldn't see any of the letters on the chart. All she could do was count fingers. And now she's presenting with pretty severe vision loss in the left eye of 2400. And then we got an MRI. You can see this enhancement of the optic nerve pretty much going down a large portion of the nerves, something we typically see in NMOSD. And unlike MS, when you get an MRI of the brain, we don't tend to see all the scars that you have with MS. With MS, you often have these little scars scattered out because MS, essentially multiple sclerosis, stands for multiple scars. You accumulate scars in the brain. With NMOSD, you don't tend to have as many of those lesions in the brain. Now, in terms of the visual outcomes after NMOSD optic neuritis, unfortunately, over a third of patients end up legally blind after an optic neuritis attack from NMOSD. And only about 40% of patients end up with that vision of 20/40 or better, allowing them to be able to drive without restrictions. There's a newer disease entity called MOGAD, Bog Antibody-Associated Disease. This was essentially recognized in about 2015. And patients with MOGAD optic neuritis often present with pretty severe vision loss, like this patient here, present actually with bilateral optic neuritis, count fingers vision in both eyes. Another striking feature about MOGAD optic neuritis is there tends to be more optic disc edema. So when we look at that optic nerve, it looks pretty angry, where in NMOSD and MS, oftentimes the inflammation is further back along the optic nerve, so the optic nerve doesn't look as swollen. With MOGAD optic neuritis, you tend to have a lot of inflammation in the optic nerve, so much so that it spills into the orbital fat, and these are features of MOGAD. The good part about MOGAD is they tend to be more steroid responsive than NMOSD. So even though they present with very severe vision loss, only 5% end up legally blind, 2200 or worse. 91% of patients end up 20/40 or better. So the outcomes are more similar to MS, despite presenting with very severe vision loss. And so one of the questions that patients often have is, well, what does 20/20 mean? What does 2200 mean? So I thought I would just step through what a visual acuity chart means. So essentially what 20/20 means is that at 20 feet, you see what a normal person sees at 20 feet. So 20/20 is normal. What a 2200 means is that 20 feet, you see what a normal person sees at 2200. So essentially, if you just see the top E, that's all you can see at 20 feet. That's what a normal person would see if they're sitting right here at 20 feet. And then, so again, an affected eye at 20 feet would only be able to see this big E, and that's considered 2200. Another thing that's important that we check in the on the eye exam is the pupil exam. We essentially take a flashlight and we swing it from eye to eye, and we're looking for a relative afferent pupillary defect, an RAPD. Essentially, what we're measuring is how much light is reaching one eye versus the other eye. And if there's an RAPD, that means there's disease either to the optic nerve or retina in one eye compared to the other eye. It's 100% objective. And so therefore it's going to be normal in patients with functional vision loss. And it actually isn't affected by cataracts, glasses, essentially vitreous hemorrhage, which is blood within the eye. And RAPD is going to be there for pretty much every single optic neuritis with vision loss, unless it affects both eyes completely equally, because again, it's relative to the eye. I just have here a video of what we're looking for. And so you can see here, I shine light in the right eye and it constricts. I shine light in the left eye now and it constricts as well. And so at this point, both eyes are actually getting some light, you can tell. Now what we do is we swing the flashlight back and forth. And you can see when I swing it to the right, the pupil dilates a little bit. Swing it to left, it constricts more briskly. And therefore, the right eye has a relative afferent pupillary defect. That right eye either has something wrong with the optic nerve or the retina, which you can see here by us swinging this flashlight back and forth. And we can actually quantify the degree of the APD by putting these neutral density filters, these essentially photograph filters, by blocking light into the good eye, and we can balance the constriction of the light. And so that's how we measure RAPDs. And again, this is very important in our assessment of patients with optic neuritis because it provides an objective evidence that there's optic nerve dysfunction. And again, these are those neutral density filters we can do to quantify the RAPD. The other tests that you're going to get in the eye clinic are visual fields. This is the most common visual field machine we use, which is called the Humphrey Automated Visual Field. And essentially, it's going to mark out, it essentially checks the central 24 degrees. It'll mark out your natural blind spot, which is normal. And it looks for areas that are missing vision. And essentially what the patient is going to see if they go into the machine is they're going to see this flashing light. And the job of the patient is to click the button every time they see the flashing light. And that essentially maps out the peripheral vision they can see to the side and also to the center. And so what you're going to see now are these flashing lights to the side. And again, every time you see that light, you click the button, and then we can map out the peripheral vision that way. And so visual field defects are very common with optic neuritis. The most common is just kind of diffuse depression, going from mild depression to very severe depression. But you can have any pattern of visual field loss with optic neuritis, where you sometimes lose half of the vision or the peripheral vision. Any pattern can be seen. It's important for us to look at the visual fields and look to make sure they're reliable. So this is the left eye visual field where it's completely normal with just the enlarged with the normal blind spot, which everyone has. And you can see in the right eye, it looks like the patient's missing a lot of vision, a lot of black. But this patient had 53% false negatives. So that means 53% of the time when there was a light that they should be able to see, they were not clicking the button. And so this is an unreliable test. And for us, it'd be important to look at how well that pupil constricts to light to see if there's any objective evidence of an optic neuritis attack. This is what we call a cloverleaf pattern. And again, it just shows that it's pretty unreliable. And so again, we would be looking for an RAPD. If there's no RAPD, this would be functional vision loss, which is a condition where the patient can actually see, but for some reason the brain doesn't register it can see. But the good part is it's not neurologically dangerous. It's not caused by optic neuritis. Another way we can check for visual fields is a Goldman visual field where a patient is actually talking with the perimetrist and they pull in lights from the periphery and they can actually mark where they can see and they can't see. Another test we often do in the eye clinic is color vision tests. The most common one you'll probably see the Ishihara color plates, but we can also have patients line up these color palettes to kind of look at how their vision is. And with optic neuritis, oftentimes one of the first things that happens is colors become less vibrant. This tool I wanted to talk about a little bit in more detail is optical coherence tomography, OCT. If you have optic neuritis, you're definitely going to get a visual field test. You're also probably going to get an OCT as well. What an OCT is it's very similar to an ultrasound, but instead of using sound, it uses light. And that is what allows us to have micrometer resolution. So this is actually an eyeball, a dissected eyeball where post-mortem, you can see every single layer of the retina. But this is an OCT image where you can see all the layers of the retina as well. In fact, this OCT image is actually an image of my own eye taken undilated. And you can see every single one of these layers of the retina. The ones that are important for optic neuritis is the RNFL, the retinal nerve fiber layer. These are the axons that give rise to the optic nerve. And during an acute attack, sometimes it'll be thick. And after an attack, it'll become thin. The other layer that's important are the ganglion cell. These are the cell bodies that give rise to the optic nerve. And after an attack of optic neuritis, these layers will get thin. And this layer is important for looking for other causes of vision loss. The ellipsoid zone are actually your photoreceptors. And so if we see photoreceptor disruption, it's not optic neuritis, it's some other cause of vision loss. And this is a typical readout you get from OCT where it's actually color coded. Green is, this is a patient with normal thickness, and it's color coded where green is normal, white is too thick, yellow is mildly thin, and red is too thin. And so this is something we can use to monitor our patients. During acute attack, OC can actually quantify the amount of optic nerve swelling by measuring that RNFL. This is just an example of a patient with NMOSD. During the acute attack, we don't see that thickening, but during MOGAD optic neuritis, they tend to have more disc edema. And you can see here the thickness of the attack in the left eye was 215 microns compared to an attack of NMOSD, it's only 93 microns. So again, MOGAD tends to cause more thickening, and that can actually help us differentiate the two. There was a study done in collaboration with Dr. Eisenberg and many other international MOGAD and NMOSD experts, where essentially this on the y-axis is how thick the nerve is, and this is MOG optic neuritis, this is NMO optic neuritis. And you can see in MOG optic neuritis, there's a lot more patients with pretty thick nerves during the acute attack. And with NMOSD, it's pretty rare to have a lot of thickening. And so even before those antibodies come back, as a clinician, if I have a patient with optic neuritis and I get an OCT and the RNFL thickness is 300, I'm thinking this is probably MOG and not going to be NMOSD. And so that's how we use it clinically. OCT is also very important, and this is probably even more important, is to help quantify the damage after optic neuritis. And so this is a patient with optic neuritis in the left eye, and after the attack, this was an animal patient, you can see pretty profound thinning of the retinal nerve fiber and ganglion cell. And so again, it provides objective evidence that the attack was from optic neuritis, and this tends to correlate roughly with visual outcomes as well. So again, OCT is helpful in the acute setting and very important afterwards to confirm optic neuritis attacks. In terms of what happens after animal optic neuritis, it does tend to cause much more thinning than MS. It just causes more damage. So this was a nice study where they looked at multiple studies on OCT and optic neuritis, and at the zero axis, this is if NMO caused equal amount of thinning between NMO and MS. All the studies would kind of line up here. But you can see that they're all shifted to the left because all the studies are demonstrating that NMO causes more severe thinning of both the retinal nerve fiber and ganglion cell compared to multiple sclerosis, which correlates with that poor outcome. MRI is also very helpful for us to confirm an attack and also help differentiate the cause. With NMO, it tends to cause a good long amount of optic nerve enhancement, and about 20% of the time it can affect both nerves. And so we're looking for that to help confirm the attack and also help say this may be NMOSD even before those OCA4 antibodies come back. It's important for us to use the right scan. We need not only an MRI of brain, but we need an MRI of the orbits with contrast. If you just have an MRI of the brain without fat saturation, we actually can't see that enhancement or inflammation of the optic nerve. This is that same patient, but here it's so clear that there's light up, but if you don't have fat saturation of the orbits, you're going to miss that. NMOSD also likes to affect the optic chiasm where the optic chiasms cross. That happens about 20% of the time in NMO. In MS, it only happens about 2%, 3%. So if we see chiasm involvement, our radar is up for NMOSD. And so these are just different ways that MS and NMO and MOG tend to present. Again, with MS, it causes a short segment of inflammation. And they tend to have these scars, which we call periventricular white matter lesions. With NMOSD, it likes to affect the chiasm and it likes to affect the spinal cord and cause a lot of deficits there, often making it difficult to walk. With MOGAD, they tend to have a lot of optic disc edema on exam. They like to have a lot of inflammation in the optic nerves, and sometimes they can cause diffuse inflammation in the brain, something called ADEM. And so these are the visual sequelae from optic neuritis. We talked about decreased visual acuity, decreased visual fields. And essentially, we're going to test our visual acuity with our Snellen visual acuity charts. But sometimes patients are 20/20, but they say, I'm 20/20 on the chart, but I still can't see well. And it may be because they've got decreased vision. Again, this is a normal visual field, but this is a patient with perioptic neuritis who has a lot of visual field loss. So even though they're 20/20, they may have a lot of peripheral vision loss that's preventing them from being able to see well. Some patients will be 20/20 and have a normal visual field and still say they can't see quite well. And that's because it's very common after optic neuritis to have decreased contrast. And so this is what I mean by decreased contrast. This is essentially a patient with normal contrast, and this is a patient with prior optic neuritis and how they would perceive the world. They often have reduced contrast. Even though they're 20/20, they may have decreased contrast. And that's very, very common. And we can actually test that on our charts. This is your normal Snellen chart, high contrast visual acuity. And this is a low contrast chart where it's harder to see the letters, but a normal person can still see the 20/20 letter, whereas a patient with perioptic neuritis may only be able to see the 2100 letters. Another common thing, and again, decreased contrast is very common after optic neuritis, even after recovery due to 20/20. Light sensitivity is also very common after optic neuritis. It's interesting. You'd think if you're losing optic nerves and you're seeing less, you'd think you'd be less sensitive to light, but it's very common for patients after optic neuritis to have light sensitivity. And something that we often suggest are FL41 lenses. This tends to block the painful wavelength of light and can be helpful for some of our patients with light sensitivity after optic neuritis. Another symptom that patients often have is Uthoff's phenomenon. Oftentimes, this is associated with MS optic neuritis, but it actually can occur with any optic neuritis, including NMOSD and MOGAD, where essentially they get transient blurring of their vision with heat or exercise. What happens if you have prior optic neuritis, even if you recover back to 2020, the signal's still not quite as fast as it used to be. And if you get hot or if you're exercising, that signal actually slows down and they'll get transient blurring during that episode. The good part is it does not cause any permanent optic nerve damage. And so patients are often concerned, if I exercise and the vision's getting blurry, is that going to trigger damage or trigger an optic neuritis? And it's not the case. So it's just a phenomenon that we know, but it's not dangerous. And then Pulfric phenomenon is very interesting. Optic neuritis, as we talked about, slows the signal down the optic nerve. But if the other eye is normal, you have one eye with slower signal, one eye with faster signal, and essentially an object traveling in a 2D path are actually perceived to be in a 3D path. And so this is just an example of that. So essentially, if you've got an object going back and forth like this, and you have optic neuritis in one eye, it's actually going to look like this. And so that ends up causing some issues with movement perception, depth perception, things like that. And so it's pretty common for patients to have some issues with kind of visual processing, even if they're recovered back to 2020. Now, what are some options we can do for patients with visual impairment that didn't recover with treatment? There are state services for the blind, and you don't have to be blind to actually have these services, but you can have state services of visual impairment essentially, or they'll actually go to your house, make sure that things are safe, and there's other options as well. There's also talking books, watches, iPads. There's increased technology that's available for patients with low vision. And there's low vision optometrists who their job is to specialize in optimizing the vision you have. And so that may be getting thicker reading glasses. The standard reading glass is a plus 2.5, but they have options of plus 5. We can hold things closer to higher magnification. They'll offer handheld magnification, electronic magnification, different filters for the light sensitivity. And so low vision optometrist is going to have the most up-to-date technology to be able to help with your vision. And there's some better technology kind of on the way, including the ultra cane. So instead of a cane that actually uses ultrasound to be able to look for objects that you might bump into if you're visually impaired in both eyes, there's something called OrCam where you put on the glasses and you actually just kind of click on the camera and it actually can read for you. eSight allows for this magnification of images, allows for improvement in your visual quality. And there's this app called Be My Eyes where actually volunteers will actually help. Essentially, you have a camera connected, and what you're viewing, you're going to be connected to a volunteer, and they're going to describe which you can see based on the camera, and they can help guide you. And so these are some technologies that can help with patients with low vision. And in terms of the future vision loss, it'll be ways of trying to improve that vision. And so we currently have cortical visual implants that can be implanted in the cortex if both optic nerves are completely blind. You can actually have these cortical implants. Right now, the vision is very rudimentary. Essentially, being able to see movement and maybe a shape. So essentially, this is reserved for patients who are completely blind from optic nerve disease. This is an option. One example is the Orion visual cortical prosthesis system. There's several clinical trials ongoing on this right now. But it's an option for patients completely blind because the kind of vision we get from this is very rudimentary, really kind of seeing movements, seeing light and dark. There are clinical trials in the U.S. for electrostimulation of the optic nerve. This is offered by Fedorov Restore Vision Clinic in Germany. So far, we don't have any definitive clinical evidence that it works, but the idea is essentially if you use electrostimulation, can you kind of increase the signal down the optic nerve? Again, hopefully these randomized clinical trials show some benefit. Again, from my experience, it hasn't been any large benefits that they've been noticing. But right now, there's clinical trials for glaucoma. And if it works for glaucoma, then this may be something we may apply to patients with prior optic neuritis as well. And I think the biggest future of treatment will be stem cells. Essentially, this is just a study where using stem cells to grow this organoid with these optic nerve structures, essentially in a cup. The drawback right now is our technology is not quite there. We can grow optic nerves in a dish, but we don't know how to make those optic nerves grow from the eye to the middle of the brain, which is its very first connection needs to make. And so there's no evidence that any of the stem cell treatments are working right now. And unfortunately, there's reports of patients actually going blind from stem cells injected into the eye. So until we get this working in animal models and then working in humans, I would avoid any stem cell treatments for optic nerve damage at this time. But I think this will be the future. So essentially, this is a nice schematic of what we can offer for vision loss and where we're going. Right now, we have low technology. We've got higher technology for vision loss. Future will be cortical implants, which is really right around the corner, but again, pretty rudimentary vision. And the future will be stem cells and possible gene therapy for restoring vision. But that's where we're going. So hopefully from this presentation, you were able to take away these main clinical pearls. One is that NMOSD causes very severe vision loss. A third of patients end up 2200 or worse, which is legal blindness in that eye that it gets affected. The vital signs of vision are visual acuity, color vision, our pupil exam, visual fields, OCT, and MRI. This is how we confirm optic neuritis and quantify the amount of damage that it does. We talked about how optic neuritis causes vision loss beyond just a decrease in visual acuity. It causes decreased contrast, light sensitivity, UTOS phenomenon, photic phenomenon. So different ways that it can affect the vision than just being worse on that visual acuity chart. And we talked about the options for visual rehab at this time. And I think the technology is just going to keep getting better. So I just want to thank you all for your attention, and I will turn it back over to Dean.
Well, thank you, Dr. Chen, for that excellent update, very comprehensive and illustrative of the techniques that you use to help confirm a diagnosis of optic neuritis, investigate visual symptoms, and the research that's going on, which is very exciting. So a few questions that come up from your presentation. The first would be, what are treatments for acute optic neuritis when it first happens?
Yeah, so if you have acute optic neuritis and we confirm in our examination, we're going to treat him with a high-dose corticosteroids. Typically, it's IV methylprednisolone for 3 to 5 days IV. Another option actually is high-dose oral prednisone. We can actually do prednisone pills, 1,250 milligrams, which is equivalent to what we give IV. The drawback with the pills is the largest prednisone tablet we have is 50 milligrams. So they actually have to take 25 tablets all at once for 3 to 5 days. And then depending on the type of optic neuritis, we may be more aggressive. With NMO, we know the outcomes are pretty poor. So we do this treatment called plasma exchange to essentially wash out the pathologic antibodies. And so that's oftentimes what we do for NMOSD. And it looks like some of the audience wants to know, is this something we should do for our NMOSD attacks? And I would say if it's a severe NMOSD attack, it's something that we think we should do. As we talked about, over a third of NMOSD attacks end up 2200 or worse. And so we're going to try and shift that, down to, 5% and less. And we think that plasma exchange is helpful there. And we think that earlier the better. It leads to better outcomes. And so again, it's plasma exchange. The drawback of plasma exchange is it often requires a central line, and that can have potential complications. And it's pretty time involving and intensive as well, often 5 to 7 treatments every other day, so often requiring hospitalization. But again, the idea is you're taking a patient's blood, using a plasma exchange to wash out the pathologic antibodies and then giving them back plasma that does not have those pathologic antibodies. So again, NMOSD attacks, if they're severe, we're doing it. Now, other kinds of optic neuritis, if it's severe, we'll start off with high-dose steroids. And if they don't respond to the high-dose steroids, then sometimes we'll use plasma exchange. But NMO, we're using it pretty much as early as we can.
But you may also use it for MOGAD, for example.
Correct. Again, with MOGAD, oftentimes we'll start with steroids because oftentimes they respond so well to steroids. But if they don't respond, then we'll hand out the plasma exchange.
Excellent. Thank you. Another question, of course, really is around prediction, and I'm sure any patient who's not fully recovered their vision when you see them is asking you this question, will my vision come back? How can I tell if it's coming back?
Yeah, so when you have an acute attack, we're going to treat you aggressively with IV steroids and possibly plasma exchange, potentially even IVIG, is another treatment you could potentially do. But again, we're going to treat you during that first 2 weeks or 3 weeks, even up to a month out, um, with these treatments. And then it's just going to be time whether it recovers or not. And majority of the recovery happens in the first 1 to 3 months after an attack. And then patients can have some gradual mild recovery over a full year after the attack. And 1 year after the attack, what vision you have is essentially going to be where you're going to end up. And so again, our job is to treat it aggressively early on and then hope you get further recovery over the year.
Very good. It's interesting that despite the visual impairment in optic neuritis being caused by inflammation in these different diseases, that the outcomes are so different. Why are the outcomes thought to be so poor for many patients who have NMOSD related optic neuritis?
I think it all comes down to the pathophysiology of the disease. With NMOSD, you have these aquaporin 4 antibodies that bind to aquaporin 4, and these are there's a lot of aquaporin 4 in optic nerves, which is why it likes to affect the optic nerves. And when that happens, it activates this process called complement. And when the complement is activated, it actually causes the astrocytes to actually die. And astrocytes are very important in optic nerve function. And essentially, when they die, it leads to very poor optic nerve recovery after an optic neuritis attack. So again, it boils down to different pathophysiology. Whereas with MOGAD, it tends to be more purely inflammation, and that's why it's more steroid responsive. With NMOSD, it's acting through complement and leading to these pretty poor outcomes.
Right. Um, are there any ongoing clinical trials for optic neuritis?
Yeah, there's a couple that we can talk about. One is called timely plex, which is we talked about plasma exchange and how we think early plasma exchange is associated with better outcomes. But a lot of that is dependent, it's entirely dependent on retrospective studies, which makes it hard to know if it's truly that important to be doing early versus delayed rescue plex. The reason why I say that is essentially if you've got a patient who we're seeing them within a week and they're getting plasma exchange, a lot of those patients are going to recover even without treatment. And we know with optic neuritis, it can get better even on its own. Whereas if you've got a patient 1 month out and they're still doing poorly, that's a subset of patients that's going to do destined to do more poorly. So even if you're doing plasma exchange at 1 month and it looks like the outcomes are worse compared to when you treat them within a week, a lot of that's just because you're selecting for patients that are already going to do poorly. And so this clinical trial called Timely Plex is going to be looking at patients with a severe optic neuritis, severe transverse myelitis, and we're going to randomize them to either getting IV steroids alone and then rescue Plex if they don't recover at 1 to 2 weeks, or they're going to get plasma exchange and IV steroids right at the same time. And we really don't, as clinicians, don't know which strategy is better because plasma exchange has potential complications. And so if a patient doesn't need it, we don't necessarily want to be doing it right away. But if this timely plex trial shows that it is important to give right away, that will change our management and patients will get it right away. Or if it demonstrates that giving it 2 weeks later is just as good, then that will be the way we manage our patients. And so that's an important clinical trial that's currently enrolling patients. So something to definitely look out for. So there's going to be an upcoming clinical trial for this treatment called Provosegtor, and it's thought to be a neuroprotective treatment for optic neuritis. There is a small study suggesting that it led to improved low contrast visual acuity in patients treated, and so that'll be a upcoming randomized clinical trial to look out for that many sites around the world will be involved in.
Oh, that's very exciting. Um, when I'm sure ophthalmologists, or neurologists see patients who have new visual symptoms. Sometimes it's a challenge to tell whether their change in symptoms is a true relapse or recurrence, another event of optic neuritis, or whether it's what we call a pseudo relapse, which is something that's a visual change, but it's not a true new inflammatory event. How do you approach differentiating those possibilities, which are quite important?
Yeah, no, this is a very important question because if it's a true relapse, that means that they may need to be on stronger chronic immunotherapy. Their treatment's not working. Whereas the pseudo relapse, it's not going to cause any permanent deficits, and we don't have to change treatment. So differentiating the two is very important, and it's very common in a patient with prior optic neuritis to have some good days and bad days to potentially be concerned that's an optic neuritis attack. So there's a couple of things that we check. One is visual acuity and visual fields. But there can be some subjectivity to that. And what I mean by that is some patients can actually have functional vision loss where on that given day or that given week, they think they can't see, even though they can see better. And so what's really important to confirm optic neuritis attacks is to have objective evidence. And so one is looking at the pupils for that relative afferent pupillary defect. If that pupil no longer constricts as briskly as it did before, that's definitely an optic neuritis attack. Visual field patterns are helpful to look at, and we can look at the reliability indices. OCT is very helpful. If there's acute swelling in the nerve, we know that's an attack. Or a month later, if there's thinning of the retinal nerve fiber or ganglion cell, we know that was an attack. And MRI is very important. Essentially, at least 90% of optic neuritis attacks, probably even higher, will have enhancement or inflammation on the MRI that we can visibly see. And so these are essentially the tools we use to confirm an attack. And again, it's very important because it helps determine how aggressively we have to treat that acute attack. And more importantly, do we change our chronic immunotherapy?
Yeah, excellent explanation. That is a critical issue, both for general practice, that is, people in their day-to-day lives who are reporting new symptoms, and then also for clinical trials where it's critical that we identify whether a new event is truly a relapse or not to figure out whether a drug or other treatment is working. That's excellent. The last question we had is, you probably ask this quite frequently, but would you recommend stem cells for vision loss right now?
Unfortunately, the answer is no at this time. Again, at this present time, we can actually take, let's say, your skin and grow an optic nerve in a dish. And so it's very tempting to say, well, I've got an optic nerve in a dish. Why don't I just put in your eye to try and get your vision back? The drawback is these stem cells, these optic nerve cells, have to grow from the eyeball to the middle of the brain before they make their first connection. And at this time, we don't know how to make those optic nerves grow to where they're supposed to grow. And so currently there's a lot of research being done in animal models using electromagnetic waves to try and stimulate the optic nerves to grow in the right direction. And so we're heading in the right direction, but we have not gotten it to work yet successfully in animals. And so once we get it working in animals, then I think it'll go to human clinical trials. The other drawback of stem cells right now is not only is it very costly because there's no insurance that's going to pay for it, but again, there have been reports of patients going blind from these injections. Not only blind, but actually it causes inflammation. So they have a painful blind eye. And so some patients are like, well, I'm already blind now. There's no harm in doing it. It can actually cause inflammation and pain. So until there are animal models proving it works and then clinical trials in large academic centers, I would avoid these stem cell clinics that you can find around the world.
Okay, thank you very much for clarifying that. Well, that was an outstanding presentation and update, Dr. Chen. Thank you very much for taking the time to share your expertise and perspectives to both clinicians and patients who are affected by these diseases or who see them in their practice.
Oh, thank you so much, Dr. Wingerchuk, for having me.
We hope this presentation has been helpful. To access this session and others in the Masterclass series, please visit the Patient Health Alliance website. You can use the QR code shown here. The website links directly to the PHA website is also shown below. Finally, the NMOSD Masterclass is sponsored by an educational grant from Alexion AstraZeneca Rare Disease. We're grateful for their support for today's presentation and for the series. Thanks again to Dr. Chen for his outstanding presentation, and we hope you enjoyed it. Thank you.